to say I'm so excited to be here and see all of you again. It's just, I'm going to forget everything I want to say because I just want to sit down and chat with you. But as Daniel said, I was so privileged to be a part of the group that launched open data for California. And I'm equally lucky to move on to another exciting position at Esri. And I'm Esri's Chief Medical Officer and Health Solutions Director. And we're a 46-year-old company. And our mission is really to enable people to positively impact the future by, and I should show you my slide, because it's so colorful, to positively impact the future through a deeper geographic understanding of this incredibly complex and changing world around us. And very soon I'm going to introduce somebody who's doing exactly that. But before I do, I really just want to tell you 3 things about Esri's open data solution, just in case you didn't know. It's called ArcGIS Open Data. And the first important thing that you should know is it's easy. You know, in today's world, and you all know it, there is an increased expectation for simplicity and intuitive kinds of technology. And so in our open data portal, you actually don't have to know any programming, no code. It's a configurable solution that you can actually do in an afternoon. The second thing that I want you to know is that you can discover data quickly. We actually had something I think is very exciting about 1 month ago, a brand new release that features a master or federated data catalog. And this is what it looks like. So now with this federated data catalog, you can search for data by topic, but also you can search by place or a combination of the two to get the data that you want very quickly. And as of this morning, you could explore 21,928 open data sets from this portal from 1,634 organizations. And to give you a sense of how fast it's growing, we added 19 organizations yesterday, a Sunday. Okay, so people are doing this and it's pretty quick and easy. The third thing I wanted you to know is I'm not selling it, you may probably already have it. Okay, so if you don't know if you have it, you can talk to me or Angel. Angel, can you raise your hand? And we would be very happy to help you with that. But speaking of helping, that's actually our next presenter's life's work. When we first started corresponding with me in Southern California and him in Nigeria, I was actually charmed and thrilled to find out that he's a UC Davis alumni. Like me, go Aggies. And he actually got both his master's and Ph.D. degrees in pharmacology and toxicology there. Now, after his Ph.D., his doctorate work, he was selected as a presidential management fellow, and he began working at the CDC. While he was there, he developed expertise in epidemiology, and then he started to do additional training in vaccinology. So with that new knowledge and expertise, he started to work with the World Health Organization on vaccine-preventable diseases, such as measles and polio. And we all know how relevant that is. He spent time in Nigeria, and he provided technical support to traditional kinds of immunization programs, and then also did capacity building for healthcare personnel. And a big part of his planning and intervention strategy was through using open data and GIS mapping. So it seemed a really natural progression of his career to move on with this work through the Bill and Melinda Gates Foundation. Now, he has humbly said, "I try to put my efforts into projects that have a beneficial impact on the communities here." Well, he's done that and a whole lot more. And it's my honor to welcome a true public health hero, Dr. Vincent Seaman.
Thank you, Este. Is this the... Okay, so this is a great honor to be here, and I appreciate you staying into the afternoon. I know if I were a local person, I'd be looking at my watch going like, oh, what time is it? And it's funny because I used to be a resident of this area for almost 15 years. In fact, the last time I was in this building was 2002, and I was a senior class advisor for the El Camino High School class of 2002, and we were having the senior prom here. And they took the pictures in the vault and everything. So any El Camino alumni here? Usually there's one in every crowd. Anyway, so it brings back old memories. Now I have a bunch of slides, a lot of pictures, but I'm going to go through them pretty quick. But I've been told that you will get the slide deck, and you can also contact me personally if you have any questions. So I'm just going to quickly run through what we did in Nigeria and how that relates to open data, and maybe stimulate some ideas that might be relevant in other places. So to remind you about polio, unless you're my age, you probably haven't dealt with polio as a disease. But in 1988, it was endemic in over 125 countries of the world, and there's 1,000 children being paralyzed on a daily basis. And we've progressed to now only 3 endemic countries: Pakistan, Afghanistan, and Nigeria. And hopefully, in the next year or two, we can get rid of polio once and for all. And so my focus is in Nigeria, and we have other teams working in the other 2 countries. So just a little explanation how the polio vaccination works. In these countries, the goal, usually there will be a national immunization day well, in Nigeria, it's usually every 6 weeks or so. And the goal is to vaccinate every child under 5 years old. So just think about that here. Think about trying to vaccinate every child under 5 years old in Sacramento or wherever your hometown is. I mean, it's a logistical challenge, operational challenge. I mean, even with the resources we have, it would be a huge task to do. And then imagine doing it in a place like Nigeria, which has, little human resource capacity, no infrastructure like internet, computers, in the places we work, cell phones, maybe that's about it. It's daunting, to say the least. And the way it works is there'll be a micro-planning meeting early on where the village elders will get around and they will try and plan out sending these vaccination teams to all the different communities in their area. And in Nigeria, we do this at the ward level. So there's 37 states in Nigeria, and then each state is composed of local government areas, like counties for us. And then each local government area is divided into 10 or so wards. So the ward level is where this operation occurs. And once they have this plan, they will have a certain number of teams allocated, and they will have a plan for each team to go to certain settlements. They have a training session where they train all the workers. Most of them are women, because men can't go inside the houses up in the north. It's predominantly Muslim, and so, it wouldn't make much sense to send men out in the field. There's a flag-off ceremony at the beginning of the campaign, and these are 4 days, so they have 4 days to reach all the children. And then once they reach the child, it's just 2 drops of this oral Seaman vaccine. So it's relatively simple in that respect. When a child gets vaccinated, they mark the left little finger with a silver nitrate marker, which stains the nail. And so if we want to do a coverage survey or something like the week after, we can go and see if a child was vaccinated or not by checking their little finger. And then there's 2 different strategies. It's mostly the house-to-house strategy, where the teams go to every single house and find out if there's children there and vaccinate them. And then they will also have what we call fixed posts, which would be a clinic like at a school or a market or places where we expect people. And people go to any lengths to do this. It's really incredible, some of the things that people do to reach children. These are pictures from India, and India finished the eradication process over a year ago, and we hope to be next in Nigeria. So I'll quickly talk about the GIS work in Nigeria. We have a population model that we think could change the world. And GIS support in other countries, and then a big project we have with making core data layers for the developing world. So here's an example of one of the maps I ran into when I first went there. And this is what they were using for planning. And you can see that it's not very detailed. And I think the local people probably understood it, but we just felt that we kept running into things like this, and we just knew there were places that weren't being visited. So what we started doing is actually going to all the states in the north, which is where the polio was circulating, and still the last case was in July of last year, but that's the part of the country that we had to deal with. And we actually sent people to every settlement and collected with a GPS device, collected coordinates, names, and places of interest like markets, health facilities, and things like that. And we created these coordinate-based maps that then they could use for planning. And we also use those maps for tracking vaccination teams. So when teams would go out, we would give them an Android phone with a GPS app that would collect a point every 2 minutes. And when they came back, we would upload the data and overlay it on those base maps, and we could see if there were any settlements that had not been visited. We don't really know what the teams did when they got there, but we know that if nobody went to a settlement, that means nobody got vaccinated. So we could use that for follow-up and such. We found over time that there were chronically missed settlements, places that we kept telling them, like, nobody went to this place, and they would not seem to find it. And so we recognized that there was a problem with the people not knowing how to get there. So we developed a tablet application to help people find those places. We use digital elevation layers. So these are elevation contour layers that you can get now for free. To determine where the best sites were to do environmental surveillance. So for polio, it doesn't have a non-human host, and it only lives in the environment for a few weeks. So one way to do surveillance in urban areas is to sample like sewage or wastewater and see if you can pick up any virus in that. So we do that a lot, but there's no good way of determining, like, where should you collect this sample. And we found that a lot of times they would maybe collect it at a place where it was in a little hole, and it wasn't sampling more than maybe a kilometer of houses. So this elevation contour mapping helps do that. We're using this for routine immunization planning, so we can take the health facilities and put like a 5-kilometer buffer around them, and then they know that all the settlements inside there are their responsibility, and they can estimate, target population and resource needs and vaccine requirements and things like that. I'll talk about the population model in more detail, but in most of these countries, the population data is very thin. If they have done a census, like in Nigeria, the last one was 2006, and the data is not very good. And not only is it not very good, it's not evenly not very good. I mean, it's good in some places and less good in other places and horrible in some places, and you just don't know. So it's really hard to depend on it. So we need a way to estimate population without depending on that kind of information. We track the seroprevalence studies. So for polio and other diseases, the best way to know if the community is immune is to take actually blood samples and test for antibodies. And so we were able to actually map those out by collecting the home settlement for each participant. And then we could put the results on a map and actually see geographically where the areas were that were low immunity. We've developed a dashboard that we can host all the polio and immunization-related data so that if people need to respond to an outbreak or need information, it's all in one place. And this is really an accomplishment because the organizations that have to put data in, like UNICEF and World Health Organization and CDC, are typically not ones that like to do that. They like to have their own place, where they keep the data. And so instead of making a bunch of different calls, you can get it that way. And we also are doing coverage surveys based on actual settlement features. So instead of having a list of settlements and then saying, okay, randomly pick 3 and you go to those places and see if kids were vaccinated, we can use satellite imagery that has all the settlements identified, and computers can do this now really quickly. And then we randomly select, however many we need to sample, and we send people to a set of coordinates. So it's really a true sampling frame for the area that we're doing. So it's lots of different things sprung out just to the idea that we need to make better maps. So quickly, the top 3 maps are maps that you would find if you went to like OpenStreetMaps or any of the typical map databases to find a map of some place. And there's almost no information about most places that we work. A few roads and maybe a large settlement or 2. And the map on the bottom is an example of one that we made after collecting all this data. And you can see there's a lot of data that's being missed in the maps on top. These are just examples of the points of interest we collected. Over 12,000 schools, 15,000 health facilities. There's tons of places like that. And for people who need to go to these places and do work, it's sometimes really useful to know where these places are, because they may have something to do with your work. This is a screenshot of our vaccination tracking system, and it's a public website, so you can go to this website and see real time where the vaccinators are going and what the percent coverage is on a daily basis. We're right in the middle of a campaign right now, so these numbers will change each day. And this is really an incredible feat. So we are actually tracking 12,000 vaccination teams across the north of Nigeria every day. And those 12,000 teams go out with a phone, and it comes back, and we collect that phone, upload the data, give them back the phone for the next day, and then get that data onto this dashboard within 24 hours. And, for a place with power, very, very little power, no internet, it's sometimes I'm even amazed that it's happening. But this is a great website. If you drill down, you can get maps of these areas. There's reports, and it's a great tool for being able to see real time what's happening. And here's just a picture of what it looks like if you zoom into a place. The yellow dots are the regular campaign days, which are the first 4 days. And we give them feedback on what was missed. And the green dots are the ones for the mop-up day, which is the 5th day. So this is actually a way that you can show that there was impact, because you can see that people went and visited places that were missed on the first 4 days because they got feedback on where the coverage was missing. We can actually even track a single team, so you can do a filter and you can ask it for one particular team if you want to follow up. Say you have reports that this team wasn't performing well, or there's some question about whether they did the job they were supposed to do. You could actually go and look at one team, and you can even animate it, and it shows like where they went throughout the day. And each one of these dots has a date and time stamp, so you can click on a dot and it tells you exactly what time the team was at that point. So it's a great accountability tool. And then you can see where the missed settlement signs are. These are places that I mentioned, these chronically missed settlements, where even though we would give them feedback, like we'd tell them, look, this place was missed, they could not seem to find them. And it was either a problem with the name, like we told them a name and they would go someplace different. So we realized we actually had to go there with the ward supervisor who's in charge of this place to make sure that we all were in agreement on where this place was and how to get there. So we put the maps on a tablet, and we took the 2 guys on the upper right are the ward supervisors. They call them ward focal points. And then a couple of my colleagues that are with WHO are on the right there. And so we basically loaded up the information and these settlements on a tablet. And what it looks like is you look at the tablet, and it shows you where you are. So it's like you are here in a little flashing thing. And then it shows the map, and you can just tap on the map where you want to go. And it will give you a direction arrow and a distance. And if you could just use it and follow it, and the arrow will change as you change direction, but you could really use the tablet to walk to a place. And it was pretty incredible, because they didn't believe that there were some of these places were there. We would go over a hill, and there it was. And so, of course, we'd send the ward focal point in to make first contact, because a lot of these places had never been visited by somebody from outside, and you wouldn't want somebody like me walking in there like, hello, And so this father was very suspicious of vaccine and things, because they don't trust outsiders, and even the local guy had to convince him. But they bring pluses, like little pieces of candy or bars of soap or things to kind of encourage them. And he relented, so we vaccinated the child, and you can see he's getting his finger mark there. But so we did this over and over to locate and get these settlements on the map. And the residents are happy because we explained to them, look, you guys were off the radar before. I mean, people really didn't know how to find you or that you really existed. And now, you actually you're on the map. People know where you are, if there's services, if they're going to give out bed nets or whatever, you'll be included now. And I guess they could order from Amazon. They have an address now, so, maybe they're not quite there yet. So this is just a graph showing how we had hundreds of these settlements that were being chronically missed in the beginning, and we were down to 4 in December, and when we went to those, we found they were deserted places. So we actually aren't missing any anymore. So it's a real testament to the program. And then tons of other things you can do with this kind of data if you just like try and think outside the box. So we overlaid tracks from a whole bunch of rounds, and now we can use those to create transportation layers and road networks. So this is how the people get from point A to point B. And so in a place that doesn't have road maps and where there's not actual paved roads a lot of times to get to places, it's really nice to know that there's a pathway or a motorbike path or something, and it tells you how to get to someplace. Another example of the utility of this, we introduced intravenous polio vaccine or inactivated polio vaccine at the end of last year. And this has to be done at a fixed post or someplace where they can have a vaccinator that can give injections. So they wanted to make sure that they had one of these health posts within 1 kilometer of all the residents so that nobody would have to travel more than 1 kilometer to get a service, because they know by experience that people won't go further than that. So we used our software developers created a tool that clustered all settlements within 1 kilometer of a point in these groups or little clusters. And we made these maps for them. So all they had to do is make sure they put a fixed post in each one of those clusters for the right number of days. And they could we even calculated their target population and gave them the days. This is just an example of the environmental surveillance I mentioned. I won't really go through it, but this is what those sites look like. So if imagine you're standing there trying to decide, okay, should I sample here or like down at the other end of that canal? And if I do, and we get a positive sample, where did that come from? Like what area, what catchment area does that cover? Because if we want to come back and do some sort of response, we need to kind of have an idea about where it came from. And this is what the map looks like. So we know that green area is the catchment area for this one particular site. So it makes it a lot easier to have an informed response. The population is my pet project, I guess. So when I was in Nigeria, I was working there, and I would see settlements like this, and this is the same resolution imagery. And these are almost exactly the same size. They're about the same numbers of compounds or dwellings. And yet, on the official plan and the official state settlement list, the one on the left is 375 people. The one on the right is 2,675. And, you know, they don't have the ability to look at it this way, so people just kind of buy whatever the numbers are. I mean, nobody really questions them. But the problem is we provide vaccine for that many kids. And when the vaccinators take it out, they don't want to come back with vaccine because that will indicate that they didn't do their job. And so they throw it out. And then they falsify the tally sheets or the records to make it look like they vaccinated that many children. We also pay for the number of teams based on population. So that ward focal person is getting money for all these teams that he's not using. And it's a whole system of corruption that's built around inflated population. And it's not just about polio. Fertilizer allotments, other government subsidies rely on this. So and this is just a list of settlements in that general neighborhood, and the state numbers on the left, and the GIS estimate just based on counting structures is on the right. And you can see the huge difference in numbers. So what we decided to do is use the satellite imagery that we had, and we're working with Oak Ridge National Laboratories, which is a Department of Energy group, and they have a GIS group that does a lot of this high-resolution imagery processing. And they have computers that can actually, they can train them to pick out a structure, like a human structure as opposed to like non-man-made structures. And then we send people on the ground to all the different types of places and do like a microcensus and send them information and say, okay, at this house, there are so many people living here, and so many male, so many female, and here are their ages. And if we do that for enough houses in an area, you can feed that into the model, and it can then predict, kind of generalize those numbers across the board, and it can actually give you a population estimate for any user-defined area. And these are extremely valuable. So you don't have to do an administrative boundary like a census tract or anything. You can pick a settlement or a part of a big urban area or a vaccination team area, whatever you want, and get a fairly good number. And we have the first output for northern Nigeria, and it's looking really good. So far, the accuracy is better than 90% of what the hand count is. So we sent a team out and did hand counts in some validation areas that we didn't use to inform the model. And then we ran the model to predict those areas, and we were coming up within 90% or better of the actual population. So this could actually save a huge amount of money for people who do work in these kind of countries in planning, providing supplies, and all that. And there's different inputs besides the imagery. We use like nighttime lights, cellular phone records when we can, social media. There's other surrogates for people, so it's not just using imagery. And you can even tell like socioeconomic status based on the settlement or house density. So there's other information besides just numbers of people that we can get from this information. And this is just an example of the micro-census data that we did. And you can see the green dots are where the people went to collect information to inform this. This shows the dashboard. I won't talk more about that, but it's going to be helpful for people planning responses to outbreaks. I will skip that one. So we're doing this in other countries now, Cameroon, Somalia, and parts of Afghanistan. And we really need to go into Pakistan, but there's a lot of sensitivity about GIS and polio and vaccination there. So we have to be careful, but it's really, hopefully we'll be able to do that. We share all of our data through either OpenStreetMaps or other sites as we can. The picture on the left was Kano City before we started the project and uploaded our data, and the one on the right is afterwards. So I mean, we really have contributed to the information there. Now we just have to get the local people to understand how to use it. I will just mention quickly about Ebola. You know, we can't really say this publicly because the government of Nigeria has taken a lot of the credit for managing the Ebola outbreak there, which, you know, was limited to about 10 cases in Lagos. And then they managed to cap it, and it was really incredible. Well, what really happened was we used the polio contractors that we had that was doing all this tracking and GIS work in the north to come down and do the primary contact tracing. And so this is just one of the maps that they had. And they had this up and running in the first week. So there was no time lag. And if you look at the epi curve for those cases, if we would have waited 1 or 2 weeks to get something like this going, it probably would have been too late. And I just can't imagine what it would have been like if Ebola would have gotten loose in Nigeria, because those people travel a lot, and it would have just been everywhere. This is a call center that our team set up in Sierra Leone, and it shows all the calls coming in for like deaths or people worried or whatever. And so it allows you to track, okay, where are the hot spots? Where there's lots of calls coming in, where is it getting better, where is it getting worse? And it was really hard to get people to share data. There was so many agencies and groups and people working in Western Africa on Ebola. And to get them to actually all come together and let's all put our data in one place was almost impossible. In fact, it wasn't possible. So, wrapping up, this core data layers project that we have is something we feel like all developing countries, one thing that's common to them is that they have a lack of basic information. And the kind of information that we feel is common to like every project, every program, every person that wants to go work in these countries needs this kind of information to give context to their data. And it includes the administrative boundaries, the location and names of settlements, population counts and demographics based on the model I explained, so not dependent on census numbers, and critical infrastructure like transportation and roads. And so we have a project that's going to start at the second half of this year that will collect these 4 data layers. We're starting in four target countries, but assuming that things go well, we will expand and do all of Africa and South Asia. And it's a huge project. But this data would then be exposed on a publicly accessible platform so that anybody could access it and use it when they need to go to these places to do work. The other part of this project would be that the countries' governments would be partners and we would be working on building capacity within the country to use this kind of data and to update it so that this is not a static data set, but that it's updated on a yearly basis and it remains dynamic. And this is just kind of what we see it looking like, but I think that's it for my presentation. Yeah.